Ashik,
Hello.
you want to perform acute pancreatitis?
Yeah, sure.
Okay, let me share my screen so that I can show you the scenario. Before that, I'd like to put the timer. Start from now. And see my screen.
Not right now. Yes, I can see the screen.
So this is the scenario. I'm going to ask you several questions regarding this scenario, and based on
Okay.
the scenario,
Yes.
you have to answer this question. And your time will start within 30. Based on the scenario, what are the differential diagnoses?
For the differential diagnosis, is acute relapsing pancreatitis,
Mhm.
acute cholecystitis, ascending cholangitis, and pancreatic pseudocyst.
Okay. So the patient is tachypneic. Why?
Due to there is a abdominal pain and there is pressure by the pancreatic pseudocyst and maybe develop from acute respiratory distress syndrome.
Okay. Do you know any scoring system for pancreatitis?
Yes, there are four scoring system for acute pancreatitis. Like there is a Glasgow scoring system, ransom criteria, built as a CT scan scoring system, and acute physiology uh, assessment and chronic health evaluation too.
Okay. Can you elaborate Glasgow criteria?
Yeah, sure. In the Glasgow criteria score, there is involved the partial pressure of oxygen is less than 8 kilopascal. Age is more than 55 years. The total count of WBC is more than 1500. The calcium is less than 2 millimole per liter, and uh, the urea level is more than 16 millimole per liter, and the albumin is less than 32 millimole per liter, and lactate dehydrogenase is more than 600 international unit, and sugar is more than 10 millimole per liter.
So based on this criteria, when you should shift the patient to ITU?
When at least 3 of above is positive for the severe acute pancreatitis patient, we have to shift the patient into the ITU.
So do you know what is CT scoring criteria system? Can you elaborate?
Yes, the CT scan with the CT scan scoring system, it may be we found some identifying points like there is a first of all there's a normal pancreas, there's the enlargement of pancreas, then the inflammatory change in the pancreatic and peripancreatic fat, then ill-defined single peripancreatic fluid collection, and also the poorly defined 2 or more peripancreatic collection of fluid.
Okay. Do you think serum amylase is important for scoring system?
No, it's not so much important because the serum amylase level is shipped down to its normal range after 48 hours after onset of the attack, and it is not specific for the acute pancreatitis.
Okay, which enzyme would you like to check apart from amylase and lipase?
I have to check the lactic dehydrogenase.
Okay, can you please describe pathophysiology of hypocalcemia?
Uh, it has two stages. In the initial stage, there is a causes autorization of the mesenteric fat by the pancreatic enzyme, which causes free release of the free fatty acid and causes the calcium salt, which causes calcium salt and the transient hypoparathyroidism and hypomagnesemia. And in the latter phase, due to the infection, there is release increase of circulating catecholamines, which causes input the calcium into the intercellular compartment. That's why there is a relative hypocalcemia is occur.
Okay, so can you please tell me pathophysiology of hyperglycemia?
Yeah, sure. Here is destruction of the pancreatic beta cell islets of Langerhans that causes increase the glucose serum glucose level, and it also causes the stress response. For these two causes, there is a hyperglycemia is occur.
Okay, so to manage nutrition for this patient, how do you manage the nutrition?
According to the severity, if the patient is severe, we can give the total parental nutrition for this patient, and also we can do the nasojejunal feeding for enteral feeding, and we have to take into account for the patient that is the premorbid nutritional status. Have to check. Then the current we have to check the current nutritional need and review for the normal take of the fluid of this fluid. We have to check this nutrition by this manner, maintain this manner.
Okay, now pancreatitis.
Sorry, I don't get the question. Please, you please repeat again.
Yeah, sure. So can you please tell me the complications of acute pancreatitis?
Okay. Here's a complication acute for pancreatitis is a pseudocyst, and then the abscess ascites, and there is a necrotizing pancreatitis, necrosis, phlegmon, and the splenic vein thrombosis. In case of the respiratory syndrome, there is acute respiratory distress syndrome. In case of acute renal failure, it may be cause the disseminated intravascular coagulation, then hypovolemic shock, multi-organ failure, hemorrhagic pancreatitis, and systemic inflammatory reaction syndrome, and bleeding intestine and intestinal obstruction. That's all.
Okay. Can you please tell me causes of acute pancreatitis?
Yes, the causes of for acute pancreatitis are there is the gallstone and the gallstone, alcohol, then the abdominal trauma, then post ERCP, and hyperparathyroidism, hyperlipidemia, and hyperthyroidism, hyper hyperthyroidism, and we can drug for the steroid and scorpion bite.
Okay. I'm going to share our screen.
Okay.
Can you see this picture?
Yeah, sure. I can see.
Okay. So can you tell me what is this? What is this structure?
This is a liver. This liver.
Okay. This one.
This is the pancreatic pseudocyst.
This one.
This is the stomach.
Okay. This one.
This is the edematous pancreas.
This one.
This is the body of the lumbar one vertebra.
Okay. What are the CT scan findings you can find in case of acute pancreatitis?
In case of acute pancreatitis, I can found there is edematous pancreas, then the fat is trending, and there is the collection and necrosis, abscess, and pancreatic pseudocyst.
Okay. See, time is finished, but I'm going to ask you rest of the question. Okay.
Yes, sure.
So, can you please tell me the management of acute pancreatitis?
I have to manage acute pancreatitis patient according to the Krebs protocol via ABCD approach and fluid resuscitation, and ask the technical history for the patient to rule out the cause of the pancreatitis, and during the physical examination, and do blood investigations, and for full blood count, ABG, and urea electrolyte, and also arrange for ultrasonogram of this patient, and give the central venous line to monitor and hydration of the fluid balance and resuscitation and total parenteral nutrition, and we have to keep the patient nothing but oral, and give IV fluid resuscitation, IV antibiotics, and to manage the pain for the pain management of this patient, and give IV fluid, the IV anti-ulcerant, to prevent from the erosive gastritis and stress ulcer, and also give the octreotide for decrease the secretion of the pancreatic.
Okay. What is the role of corticosteroid in pancreatitis?
It will suppress the release of the inflammatory cytokines.
Okay. So, do you know what types of antibiotics used in acute pancreatitis?
There's carbapenem and quinolone.
How do you manage this pain?
There is a pethidine and meperidine is the drug of choice, but we have to consider his or her pain management according to the WHO pain ladder, whereas we first use a non-opioid drug like acetaminophen and NSAID. If the pain is not subside, then we use the weak opioid like codeine. If it cannot minimize the patient pains, so we have to go for the strong opioid, pethidine. If can, then the patient control analgesia, and go for the and last go for the can do the epidural anesthesia.
Okay. Define pseudocyst.
Pseudocyst is a amylase-rich fluid collection which is enclosed by the wall of fibrous tissue or the granulation tissue.
What are the common location for pseudocyst?
It is mainly commonly situated in the laser sac proximate to the pancreas.
How pseudocyst presents? I mean symptoms.
It presents there is a epigastric swelling, dyspepsia, vomiting, and mild fever.
Okay. Complication of pancreatic pseudocyst.
It causes the bowel obstruction, intestinal bowel obstruction, intestinal bleeding, then pancreatitis, then the abscess, systemic sepsis, and systemic sepsis, then hemorrhage into the cyst, and hemoperitoneum.
How do you diagnose pseudocyst?
You can do ultrasonogram of the abdomen, then CT scan of the abdomen, then MRCP and fluid analysis.
How do you manage pseudocyst?
Okay, the 40% of the pancreatic pseudocyst will resolve after 1 week from the onset of attack, and that time will require only the supportive treatment. If the pseudocyst cannot resolve after 1 month, or it become infected or increase the size more than 6 centimeter, it will go for the gastrostomy or cystogenostomy.
Okay. Thank you so much for your participation. I'm going to share my screen for brief discussion. So the main point is you did quite good for this station, and more than 80%, I think. But just think about timing, because for
Okay.
this session, they ask series of question and lots of question. Within 9 minutes, you may face more than 16 question. So that's why
Okay.
that's really important. When you fail to answer one question, you should not hesitate and stuck within question. Just tell the examiner that I'd like to come back to this question later. Can you please proceed for next question? So
Okay.
and for everything system, so that is not 1500, it's 15,000 neutrophil. Okay.
15,000, right? Oh, sorry, 15,000, right?
15,000, and it's neutrophil, not WBC, because neutrophil is a part of WBC. And management, when you are telling management, try to be more organized, so that examiner can understand you are organized, and for each and every question.
Okay.
I think you can develop this by repeated practice. It's okay, it's fine. Apart from that, everything is okay. Just revise 2 or 3 times. That's fine. So let me share my screen. You can see my screen.
Yeah,
So
sure. I can see.
Mikhail, can you see my screen?
Yeah, I can see it.
So this is the scenario. This was the scenario. This is the differential. You told that the differential relapsing pancreatitis, cholecystitis, cholangitis, pancreatitis, and why patient tachypneic. This 3 point is important. These are the key point. So examiner wants from candidate this 3 key point. So there are different scoring system. 1 second. So there are different scoring system, like Glasgow criteria. Usually they ask Glasgow criteria and CT scan criteria. Apart from that, they never ask the other criteria.
Ransom criteria.
Usually they never ask Ransom criteria. They usually ask Glasgow for understanding. For backup, you should go through this Ransom criteria also. So these are the CT scoring criteria. Ransom and Apache 2 criteria. So serum analysis is not important for scoring system actually. So you know better what can be the cause of normal amylase in pancreatitis, too early and too late.
Yeah. Yes.
So which enzyme check apart from amylase and lipase, there is LDH. You told that. And pathophysiology of hypocalcemia in early phase and later stage. Hyperglycemia, 2 important things is one stress response, one is beta cell destruction. And management of nutrition, just stepwise, but you should tell that I should liaise or communicate with dietitian for management of nutrition, but we can
Okay.
consider total parental nutrition or feeding through nasojejunal tube. And but we have to consider pre-morbid nutritional status, current nutritional needed, and estimation time of return of normal feeding. So that's the way of answer for this question. And complication of so should not should divide it local or systemic, but I think first should be hypovolemic shock or hemorrhagic pancreatitis. This should be first, because initially you told pseudocyst, but when acute pancreatitis, most of the patient condition resolve without formation of pseudocyst. So pseudocyst is not quite common for pancreatitis, so it should become.
Okay.
But the systemic cause like hypovolemic shock, maybe hemorrhagic pancreatitis, SRS, multi-organ failure. This is the important point of splenic vein thrombosis. I didn't ask you that question. Sometimes
Okay.
ask you low molecular weight heparin and multidisciplinary approach for splenic vein thrombosis in case of acute pancreatitis. So this is the function of pancreas, you know better, but I didn't ask that. Exocrine function and endocrine function.
Yes.
And causes of acute pancreatitis, you should mention first alcoholism, because alcoholism is a quite common cause in Western country and in UK, and then come to gallstone, abdominal trauma, post-TRCP, hyperparathyroidism, hypercalcemia, viral infection. And these are the pathogenesis for acute pancreatitis. I'll send you this slide. So this is the identification. They may ask for the pseudocyst. Can you show me the pseudocyst? Where's the pancreas, the stomach, liver, L1 vertebra. Always remember, in CT scan, it should be reverse. So usually liver should be here, but in CT scan, liver is here. It's reverse always in CT scan.
Okay.
So these are the CT scan findings. You told that, and edema of head, standing, collection, necrosis, abscess, and pseudocyst. And management should be start with ABCD, grips, center line, you can do that, and pain management, fluid management, nutritional management, infection control, PPI. So should be chronological order, and if you practice, you can do that because you know everything. Role of corticosteroid in pancreatitis, we told that. Antibiotic to use pancreas, carbapenem and quinolone that can penetrate pancreas. That's why. A management of pain according to WHO analgesic ladder pattern, it should be mentioned first. But you told that you okay, so we start with that. But you mentioned important point, that's PCA.
Sorry.
Yes. So opioid PCA epidural. So to you told epidural anesthesia, actually epidural analgesia, just remember that. Okay.
Okay. Yes.
So this is the definition of pseudocyst. You told that location of is laser sac close to pancreas, and patient may present with epigastric swelling, dyspepsia, vomiting, mild fever. This is the complication. It may be infected, abscess, GI bleeding, maybe hemorrhage, peritoneal compression. Mainly, it compresses the surrounding structure. What is the difference between true pancreatitis and pseudocyst? The lining.
There is doesn't cover and enclose, and there is no lining.
So management of pseudocyst, you told that cystogastrostomia, cystoduodenostomy. Most of the case, you should remember, most of the case resolve within 1 week. And then supportive treatment, we only do that on more than 6 centimeter or more than 5 weeks or 6 weeks. Then if complication occur or if surgeon think that it should be tamed, then you can go for cystogastrostomia, cystoduodenostomy. It's not for this station. So diagnosis of pseudocyst, routine blood investigation, And these are the specific investigation like ultrasonogram, CT scan, MRCS, fluid analysis. We can do some tumor marker to differentiate from marker, as if this one is swelling. That's why we should differentiate from tumor to viscosity and amylase also. Thank you for this discussion. Thank you for your participation.
Thank you too.
Okay.